Welcome, and thank you so much for bringing the elements to come to our forum tonight. My name is Barbara Palm. I'm one of the co-vice presidents of League of Women Voters, and we're here to hear about that important topic of single-payer health insurance. As many of you know, Dunn County voters passed by a slim margin a referendum last week that reads, "Shall Congress and the President of the United States enact into law the creation of a publicly financed, nonprofit national health insurance program that would fully cover medical costs for all Americans?" League of Women Voters does not have a position on this statement at this time, and we sought to bring together a large number of perspectives. We approached all 3 clinics in town and 4 health insurance entities that serve our area, as well as an elected official, and we were thrilled to get 2 people accept our invitation, but unfortunately they both had to withdraw from participation. So I'm sorry to report that they won't be here, but it tells me that this is a hot topic, and some of the clinics told us on legal advice they were just not able to participate. This makes me more intrigued about the topic, and I'm very excited to hear from Dr. Laurel Mark, who will be introduced in just a second. I wanted to mention that we'll have a Q&A, question and answer, after the presentation. And League members, would you please stay for a very brief general meeting after our presentation tonight. Margie Hageman, will you please introduce our speaker?
Yes, I'd like to also say just something about Clint Moses was going to come until just since election. He has meetings in Madison, and I regret the fact that he's not being able to come, and I'd like to hear what some of his thoughts on this whole topic, because he's not only a representative for us, but he's also a provider. He's a chiropractor, and so he has been a provider. I do have some cards that if anyone's interested in writing out a question as it comes to you, I have some cards that I'll pass around if you want some, so you can write questions, because sometimes by the time you get to the end of the discussion, you kind of forgotten what you were going to write. I think the reason that we really wanted to do this is we want to understand the diverse issues that are involved in the whole area of single-payer healthcare. It's talked about, but we really don't know what all the issues are. And some of you might have some ideas of some things and some concerns, and we need to make sure that we bring these out or pretend like you are a healthcare provider or an insurance company and write a question that might be asked by one of them, because we need to address these, and we need to bring our heads together with other people to be able to move forward as a country. What are the possibilities? What are the issues? And so with that, I want to introduce Dr. Laurel Mark. She is a retired internal medicine physician from Madison. She did a program for CVLR, and some of you might have attended that, and talked more about the issue of Medicare and Medicare supplements, and how the insurance industry is kind of taking over the whole insurance area, and it's a concern about how effective it's going to be with Medicare and how we're spending our Medicare dollars. But this is another issue which has been involved for many years, and has just retired as the co-president in Wisconsin of the physicians, the PNHC, which stands for Physicians for a National Health Program, and is still very actively involved, and want to introduce her as our speaker tonight. And she came up, I have to tell you too, she came up with a relative and a friend, Pam Alsom, that drove up with her from Madison, so that she wasn't totally alone on these roads tonight. So I'm going to turn it over to Laurel and let her take over.
Thank you. And let me know if you can't hear me, because I tend to move my arms around a lot, and then the mic goes with it. Thank you so much for inviting me. I also wanted to introduce Dr. Pam Olson, who is still working as an internist in Madison. We actually met each other, I think, in the same clinic floor decades ago, and she is still at it when I have retired. I have been active in the organization PNHP, Physicians for a National Health Program, since the mid-90s. We are the physician professional voluntary national organization whose sole focus is improving healthcare access and achieving universal access to healthcare. Our vision is, so I am here, I want to let you know like where I'm speaking from so that it's very clear. We believe that healthcare is a human right, and our motto is everyone in, nobody out. Our idea about this is to work on the structure that we already have, which is basically Medicare and Medicaid, expand and improve it so that it can become that robust, universal system that will actually take care of all of us. So you've probably heard a lot of people using the phrase Medicare for all. And that has become, I think, the main way that people talk about universal health care right now. But I do want to remind you that universal health care is a little different than the mechanism by how we get there. When we say universal health care, we mean everybody should have access to high quality, affordable, comprehensive health care. But getting there may take, there's many different roads to get there. We like to use the words improved Medicare for all, because most of us know that however good Medicare is, it has some big gaps. There are problems with it. It is not perfect. So we need to fix Medicare and improve it and expand it. The Physicians for a National Health Program was actually one of the first organizations to put together a proposal which has become known as single payer, which was actually put together in 1987. I'm kind of feel both proud to have been a member of this organization for a long time and working on it, and also sad that it is about the age of my children, and it's getting pretty middle-aged, and we still have not enacted it. The proposal is to create one nonprofit health insurance plan for everyone in the US. It would be publicly funded the same, in some similar way to the way Medicare and Medicaid are funded, but privately delivered. And that does differ from a lot of other ways of addressing the problem of providing healthcare to everybody. This is not going to be a talk, and I have given some talks about the history of how we got to where we are and how different countries do things. Every other peer country to us, every other industrialized, wealthy country in the world besides us guarantees healthcare to everyone who, either their citizens or everyone who lives there. We are the only ones that don't. But they do it in a variety of ways. And in some places, it is truly socialized medicine. Think of England, where there is a National Health Service. It's as if you had a VA as your healthcare provider wherever you are. Or in places like Switzerland, which is very privatized, but it still has a lot of rules. And the model that we have adopted is most similar to the model that is used in Canada and in Taiwan and several other countries, where the financing is public, but the delivery of care is private. So what I'm going to do is go through just a brief look at how we analyze, like, what are the problems with our system that need to be solved, and then our proposal for how to do that, some of the detail behind that, and then leave plenty of time for questions and discussion, because I hope what we can have is a good discussion about this. So what is wrong with our current healthcare system? One thing that we can all agree on is that our current healthcare system is not perfect. The main problem, and I will tell you this as someone who was first a specialist and then a primary care doctor, and in total had about 40 years of clinical practice, that one of the biggest problems is lack of access, that only some people actually can get into the medical system at all, because we exclude a lot of people. The second problem is that it's just plain too expensive. Whether you have insurance or not, whether you have the means or not, unless you are really, really wealthy, healthcare is just very expensive and getting more so all the time. Care is rationed in our system by income and insurance, and it's by both. You can have two people have similar jobs, work for different companies or different employers, and one will have health benefits and one will not. And then the kind of insurance you get really can determine what kind of healthcare you can get. At essence, part of the reason for this, the big part of the reason, I think, is that this is we run a profit-driven system. There is profit at every single level of our healthcare system. And what that means is that we take a lot of the money that goes into healthcare and it is diverted into other things besides medical care or public health. Despite spending a lot of money on healthcare, we have some of the poorest outcomes in the industrialized world. In fact, in most cases, we have the worst outcomes, and we'll go through that today. And then finally, it's just way, way too complicated. Anyone who's ever had to choose to buy health insurance or choose within that various programs knows that it's really a difficult system, whereas the system that is used that we are proposing would be a simplified system. So let's go through some of what that means. Lack of access. I'm sorry about this slide because I think it's a little hard to read at the bottom, but at the bottom it has the names of a bunch of other countries that are very similar to us and what percentage of their population is insured, and basically it's 100% until you get to the US, and we are at about 90. That number has changed. It's been anywhere from about 80 to 92, depending on where you are. We're about 90 again. That may seem like a lot, but we're a country of 330 million plus people, which means about 30 to 33 million people don't have any health insurance. That doesn't happen in other countries. We are the only one. And we also have a huge number of people, probably twice that, someplace around 40 or 50 million, who have insurance on paper, but they can't actually use it because of high deductibles, because of high copays, because of narrow networks. So yes, they have insurance, they don't show up in that, but they don't in fact have usable insurance. Again, not a problem in most other countries. Whoops, that didn't come through. So more Americans are underinsured than even uninsured, and that's that same kind of graphic, sorry about that. The second problem is high cost of care. Look at this, the top number there, the top bar in green is us, that's the United States. And this is this is that per capita average of spending of about $10,000 per year of healthcare consumption per capita US dollars. This was from 2017, so it's higher now than this. Next to us, the next closest to us is Switzerland. They're pretty high too. They were around 8,000. And it's interesting because Switzerland has an entirely privatized system with a lot of regulation, but they're the closest to us in terms of how they manage their healthcare dollars. And then you go down to Germany, which is around 5,700, and you keep going down. We are close to twice as expensive as almost every other similar country. Germany, Sweden, Austria, the Netherlands, just go down that list. This is actual spending. This is a combination of your premiums, your co-pays, your deductibles, what's in the system. So we spend a lot of money. Our problem here when we can't insure everyone is not that we don't spend enough money. We spend lots of money on this. Which countries spend the most? Well, we spend the most. We have the highest prescription drug prices in the world. And that is what that top bar is. That we're 1.5 times higher than everyone else. And it is eating up a huge part of our economy as well. It's not just our individual spending. It takes an enormous part of our GDP. And if you look at this slide, this has been going up and up and up, really every few years. There was a slight plateauing at around the time that the Affordable Care Act first went into place. And there was another little plateau in the first year and a half of COVID. But other than that, it's an inexorable rise. And this is just not sustainable to take over the entire gross domestic product of the country just on one industry, just on healthcare. So our spending has been growing at around 4.5% a year. That's just ridiculous, not sustainable. This slide, I think the colors came out a little strange at the bottom because the thing at the bottom doesn't really make any sense here. This is the total spending per capita, per person, in a group of peer countries, and we are at the bottom here. And this gets us up to that over $10,000 per person. What is interesting to me about this is that we spend, the stuff that's in blue, that's 6470 in blue, that is the spending we do on public spending, meaning US spending for Medicare, which is a federal program, Medicaid, a federal state program, TRICARE, which is the military program, the VA for veterans, the Indian Health Service. Those are the 5 big government programs that pay for healthcare. We spend about almost $6,500 a person. This was, I think, 2019, this data. We already have more public spending in the US per capita than France, than Japan, than the UK. UK has a socialized medical system, by the way. And they insure 100% with a much more comprehensive program. And what we get for our $6,500 is we get to spend another almost $4,000. That's private. That's your employer's contribution. That's your own co-pays and deductibles. That's out of your pocket costs to get us up to that $10,000. So I would also argue that we already have a system of spending a lot on public spending for this. This is, I don't know why this came out like that. All right, so this slide, since we have modeled our proposal on the Medicare system in Canada, the single payer, publicly financed, privately delivered care, let's compare ourselves to Canada. Up until around 1970, which is when the Canadian Medicare system actually went into effect across the country. The Canadian system actually was started in Saskatchewan, actually, in one province, and it spread to other provinces. They have a different federal system than we have, and they were able to do that. But it was really 1970 was the point at which it was throughout the entire country of Canada. And that was also, it happened to be just about the time that the HMO reorganization started in the United States, the health maintenance organizations. Up until about 1970, our healthcare statistics were very, very similar to Canada. We spent about the same amount of money. We insured about the same number of people. We had about the same kind of health outcomes, which you might expect. We are demographically not that different from Canadians. They're not demographically that different from us. Starting around 1970, we start diverging, and this is healthcare costs as a percentage of GDP. So the Canadian costs have definitely gone up, as they have throughout the world. Healthcare costs rise for a lot of reasons. But look at where we are compared. Our trajectory is much higher. We spend a lot more money than they do, and every year that gap gets bigger. Okay, what do we get for all that money? We have the worst outcomes in the world. There are a lot of reasons for that. It's not all because of spending. It's not all because of insurance, but in large part it is. So this is a graph looking again at the bottom are the names of many of our peer countries about what are considered preventable deaths. And we definitely have, the USA is the red on the left side. We're exceptional and not in a good way, because we have the highest percentage of preventable deaths of our peer countries. We also have the worst outcomes in maternal mortality, in infant mortality, the worst life expectancy. And this is compared to, in this particular slide, you can do this with every country, but this one compared to HICVs, high income countries. So high income countries in Asia, that would be like Japan, Korea, high income country, Australia, high income countries in Europe is, most of the European Union. And even Russia, which has arguably not the best healthcare system in the world, does better than we do. And then I can't help but remind ourselves here in Wisconsin that if you do these kind of analyses on a state-by-state basis, we should take a moment and sigh deeply and think about where we're at in Wisconsin, because Wisconsin has the worst maternal mortality and infant mortality rates in the country. And think about what our competition is to get to the bottom of the barrel on that. This is embarrassing, I think. And we are not just a wealthy country, but we are also a country with incredible innovation and such high quality healthcare available. And yet we have this kind of outcome. This is a population basis. Within that, there are people who do well, but I think we should be embarrassed by this. Or at least make ourselves think of, well, why is that happening? One of the reasons it happens is because it costs a lot of money and people they just don't get all the care that might be available to them. In most other countries, not all, but most other countries that we will compare ourselves to, meaning other high-income peer countries, there are not co-pays and deductibles or anything like the kind of money that we pay. If there are, they're very modest. We don't take it out of people's pockets. They pay taxes and then premiums, and it covers their care. When you start charging people things, it does get to be, and then keep on, most of us have experienced that all of these charges or all these costs are going up, and our out-of-pocket costs are going up. People do start skipping their consultations, they stop going to the doctor. We, as a matter of policy, put up barriers for that. Most of us have health insurance that will charge us if we go to the emergency room, right? Unless you're admitted to the hospital. But you can't know if you go to the emergency room with chest pain whether you were having a heart attack. You just know you're supposed to go because you might be having a heart attack. If you get really lucky and you don't have a heart attack, you get to pay a really big bill. And what do we want? We want people to stay home and not go to the hospital if they might be having a heart attack because of that bill. That is what happens. That is the kind of thing that happens so people just don't get all the care that they could otherwise get. That is because our system is really not a healthcare system. Our system is a profit system that uses healthcare as a commodity. It is really a system that's designed to make some people rich and some corporations rich and some organizations rich. It's really not a system to make you help us be healthy. It does involve healthcare in the system, but that's not its purpose. And the reason I say that, I don't think I would have said that 20 years ago, but after spending 40 years in practice And watching the changes over that time period from what it was like to be a doctor. I was a clinician my entire practice in first a hospital-based specialty practice in kidney disease, dialysis, and transplant, and then in internal medicine primary care, and with my friend and colleague in urgent care, and sometimes in the emergency room. So I did clinical medicine, and I would say that 40 years ago, 35 years ago, when I was a nephrologist, a kidney specialist, when most of my patients were at death's door, the most complicated patients in the hospital, I did less paperwork. I did less did plenty of documentation, but I did less administration and paperwork and nonsense than I did in the last 5 years when I was just in the clinic, not in the hospital, taking care of people who had, by definition, less urgent problems. Because we have really shifted what doctors do, and they spend a lot of their time doing administration, and they do it for the purpose of billing. And they have to do it for billing because at every stage, you need to document stuff in order to get paid. That is not the way the system works in most other countries. And that is because most other countries eliminate most of the profit from the system. So you don't have to do all of this billing and documentation. You do your documentation for medicine, not for money. So what we end up with is billions of dollars in profit to vary at all levels of our system. Medical bills that you can't control. We all know about surprise medical bills where you get sick, you go in, somebody who wasn't in your network that you didn't know about, or maybe some service you couldn't say no to because you weren't aware, and then you get a bill later on that's up to you to pay. Narrow networks, restrictions of who you can go to. Cherry picking and lemon dropping means insurance companies that cherry pick, they want healthy people, so they don't really have to spend a lot of money keeping you healthy. And lemon dropping is they find out that you're a lemon, that you're the one who's going to cost them a lot of money, they try to get rid of you. And up until the Affordable Care Act, they had carte blanche to do it. Now there are some rules, but there's still lots of ways in which insurance companies can kind of choose their clients. We incentivize overtreatment. So on top of everything else, we're not always providing the right incentives to doctors and providers to do the right thing, because you get paid for doing certain things and not other things. The accountability is not to patients. The accountability is to shareholders in insurance companies and often in hospitals. There's incredibly high overhead costs because of this, the crazy administrative stuff that happens. And the burden on employers who have to deal with this. The consumer information asymmetry, I think that's very badly worded, but basically what it means is as consumers, you don't even really understand, you have no control over what you're buying. I don't know, I had to go in and do a little tiny medical thing about 2 weeks ago, and I had to sign that waiver to go in. And the waiver basically says that I agree to pay whatever, and they can't even tell you what it's gonna be, right? But you've signed it away, and that's how our system works. So we expect you as a consumer to make a good decision, but you don't even know what the cost is gonna be to you. This is one of the examples of that, because we use for-profit insurance for most of our healthcare, or for a big part of it. That in the US, it's about $900 per person on average. In Canada, there is some supplemental insurance for things not covered by their Medicare program. And so it's about, what, 15% of that, 20%. We waste a huge amount of money on bureaucracy. This slide has 4 of the biggest health insurance companies in the country, and what percentage, that doesn't project very well. That is the insurance overhead. And someplace between 16 and 19 and 20%. If you have an insurance plan through the Affordable Care Act, you have to, by law, only take 15%. They have to spend 85 cents out of the dollar on actual some kind of healthcare. But Medicare, which is the little tiny green thing at the end there on the right, their average administrative costs are 2 to 3%. Because there is some administrative costs, even in running a nonprofit, publicly funded system. So the difference there is profit for the insurance company, not actual healthcare. That also applies to Medicare Advantage programs, which are run by for-profit insurance companies. This is a choice for Medicare recipients. If you choose to, you can have your Medicare run through an Advantage plan. The plan might offer you some more benefits that Medicare does not offer you. It will have a different premium, but they are allowed to take up to 15%. So they spend about 85% on healthcare, whereas traditional Medicare, their overhead is 2 to 3%. So that's a difference of just profit making. One of the reasons that things cost a lot is because of our administration. I just love this statistic. One thing that if you've ever worked in a doctor's office or a hospital, or actually I guess if you've ever been a patient, is you walk in and the first thing they ask you besides signing in is about your finances, right? Is what is your insurance card and what is covered? And you sign away that you're going to pay for what's not covered. You don't know what's covered necessarily. At the end of this, everything that needs to get billed to the various insurance companies or to you, and they all have different rules, so it requires actually a lot of people that figure out to do it right. Everything needs to be coded, C-O-D-E, and there's a code for everything that is done. There's a code for every level of office visit or hospital visit, and for every supply, and for every type of interaction and treatment. And that does take a lot of people to do. So this is a statistic from 2018. It comes from the Journal of the American Medical Association, from JAMA, which is one of the better known medical journals. And it was just one of the statistics looking at the differences in administrative costs between our for-profit system and the Canadian one. So Duke Medical Center actually has 3 big hospitals. This is in North Carolina. They have almost 1,000 beds, which is a huge hospital system, by the way. That's 3 hospitals. And they employ 1,600 billing clerks. Everyone, different insurance, all kinds of different codes, right? A comparable Canadian hospital system has 3, because Canada has a single payer Medicare for all system in which everyone has the same insurance. You don't have to have multiple things. You are going to have to report and bill what you have. And they also have other things like global budgeting. But you still do some administration. That's about 1,597 people who could be doing something else besides just billing an insurance company. I kind of hate this slide because it's another reason why our healthcare costs so much now, so much more now, and why it's so much more complicated, why it's so much more difficult and discouraging even to be a medical provider. And that is looking from 1970 to 2015 at the numbers of physicians and administrators in our country. The numbers of physicians is that little green line at the bottom. We have grown somewhat. We have slightly more physicians now than we did in 1970. I would argue we probably don't have enough because the population has more than doubled, right? But look at how many more administrators we have in our system. And I will tell you, I could feel the difference in my career as the years went by, as there's more and more people up on top, business people, analyzing and trying to figure out and tell you what to do, and a lot fewer people at the bottom actually doing it. I would argue we would like more actual healthcare providers of all kinds and fewer people administering the system. This is another example of the medic patient. This came from actually the student group at the University of Wisconsin Medical School runs a clinic called Medic for people who live in shelters and people who are impoverished and people on the street. And they do run a weekly clinic. Sometimes they do have to bring people in to the hospital or to the clinics to get care as well. And when they looked at this, they looked at the actual cost of the care that was given. And these are people who often have pretty serious medical problems. And then what was actually billed. So the cost is on the left, what was billed is on the right. And that's because we build into our system a cushion, and that cushion is not what it costs. That cushion is for other reasons, like, this is why your aspirin costs $5 in the hospital. It doesn't cost the hospital $5. It doesn't cost them that at all. But they build a cushion of profit into everything, and they kind of have to in order to deal with the system that we have. So we just have a system that does that. So that's a really quick kind of journey through what we think are the biggest problems here. You could you could do an hour of conversation about each one of the, why things cost so much, what administration looks like, what access is like for someone who doesn't have an employer who gives them good health care or health insurance. But it's just like, those are the high points. Single payer national health insurance, which is what we are advocating, AKA improved Medicare for all, is not socialized medicine. Socialized medicine is when the government provides the actual medical care, builds the hospitals, pays the employees, whatever, and it's part of a government program that almost all cases are going to be paid for by taxes. It's not socialized medicine. It's privately run healthcare, but it's funded by a publicly funded health insurance program, which is one of the definitions of Medicare, by the way. So who does it cover? A single payer, AKA improved Medicare for all program, would cover everyone. That's the whole idea of it. That the legislation would guarantee access to comprehensive, high quality, affordable healthcare to everyone who needs it. You lose your job, you don't lose your healthcare. It's not tied to employment. It's not tied to what state you live in or how much money you made in that state, because every state has a different system for Medicaid. It would just be the same for everyone across the country. And what does it include? Those of us who are on Medicare or who take care of people who are on Medicare know that current Medicare is not sufficient for all of our needs. It is not a truly comprehensive system. Medicare, so I'm going to digress for a minute. Medicare and Medicaid were enacted on the same day in 1965, signed into law by Lyndon Johnson on, this is very strange that I know this, but on July 30th of 1965. And it took 6-8 months before it was implemented, and they did it with postcards back in the 60s. No internet, no digital anything. And they got everybody who was eligible in the country signed up in 8 or 9 months by postcards. Kind of amazing. When they devised the Medicare program, it was for seniors, for elderly people over the age of 65. Up until then, it was almost impossible to get health insurance if you were older because you weren't a very good risk for any insurance company. You were likely to cost them a lot of money, and they didn't really want you. And there was no reason that they had to take you on as a client. And being older meant being poor in most parts of the country. Medicare really changed that by offering affordable, guaranteed health insurance to people over 65. It really changed the whole picture of what healthcare is in this country. But when they put it together in 1965 for people over the age of 65, they didn't put certain things in it. So it does not cover dental work. It does not cover vision, anything with your eyes. It does not cover hearing. It does not cover long-term care, which I think pretty much defines the 4 biggest needs that most senior citizens have. And in the 57 years since it's been there, we have been pushing the federal government to change that, and it hasn't happened yet. This was one of the years people talked about it, but we still don't have any of those in traditional Medicare. Interestingly, Medicaid, which is for poor people, does cover all of those things. Not at the way you always wanted to, but it does. So our vision of this is that this should be truly universal. It really should cover what's needed. It's way past time. So the key features of this Medicare for All is that everyone's covered with, just like Medicare. Medicare is a national program, the same benefits in Arizona as in Maine, as in New York, as in Kentucky. It's exactly the same benefits. You can go to all necessary care would be covered. That's improved Medicare for All. Private insurance would not be allowed to cover things that are already covered by Medicare. In most countries that do that, private insurance is for things not covered by the National Health Insurance Program. Healthcare would be paid for by taxes the same way, or some similar version to how Medicare is currently funded, which is by our federal tax money. And healthcare would be delivered by non-governmental workers. In other words, keep in place our hospitals, our clinics, our doctors, our nurses, all the other medical providers. Medicare for All or single payer is good for patients. It's good for patients because you get more choice, more access, more benefits, and a lower cost. In private insurance companies, most of them have networks or some type of way to steer you into getting your health care from one provider or another, or one system or another. Sometimes more than steer you, sometimes you're really prevented from going someplace else. If your insurance comes from your employer and you're no longer employed, you lose your health insurance. You have to either find it yourself, pay for it yourself. Benefits depend on the quality of insurance and your ability to pay high premiums. And those premiums have been going up and up. Even 10 years ago, what was considered a high deductible plan would be considered a low deductible plan today. 10 years ago, a high deductible plan was about $1,000 for your deductible. Now it's more like $5,000 to $10,000 for a high deductible plan. In Medicare for All, there are, just like in traditional Medicare, there are no networks. In traditional Medicare, you can go to any doctor, any hospital, any clinic, any healthcare provider who accepts Medicare, any place in the country. And someplace around 95% of American doctors accept Medicare, and the same thing for hospitals. It's guaranteed medical insurance regardless of your employment. And our vision is that it would cover all needed care. And that is, of course, a discussion to be had, is what is needed, right? It's good for physicians. I'll tell you, I came to this cause because I just got to a place in my practice where I was just beyond fed up by having to make the constant adjustment between what I had been trained and knew was the right thing to do, and then what was possible to do based on what somebody's insurance would pay. Not based on what they needed or any medical reason, only based on that. And not even always based on anything that made sense. So I'm not even talking about like experimental treatment or something crazy expensive. They have all sorts of reasons for having the restrictions that they have in place that are not always based on that. And I just got, I think most of the docs who have come to PNHB got there the same way, which is in our personal experience of having to give what we knew was lower quality care just because of what an insurance company would agree to. So from a doctor's standpoint, having a system where I understand the benefits and I get to apply them equally and I know who to talk to when there's a problem would be better. I would also be spending a lot less time on unnecessary documentation. And I would put the word unnecessary in there because there's very, very important to get good documentation in your medical record. But when most of it is done for the purpose of billing, that is not helpful to you. And it's not good for the doctor either. It's really demoralizing to spend a lot of your time doing that instead of actually practicing medicine. So the idea that everyone would have the same coverage, less billing time, fewer people who have to be involved in that. Cost will still be somewhat of a barrier because there are things that cost a lot of money, and no healthcare system is going to cover everything for everybody. But at least it will be understandable and transparent, and we will be able to have a public discussion about it. And I think much more autonomy for doctors. One thing that has really changed in our healthcare environment in my professional life is that doctors are not the captains of the ship. I think they were at one point, but I graduated from medical school in 1979, and that might have been one of the peak years of doctor autonomy, because in the mid-'80s, HMOs started, and that basically changed the whole focus of who decides what from doctor-patient relationships and then whatever was going on in a person's own financial life to insurance companies that then made policy. And it has just gotten worse and worse as time goes by. So I would say as much as patients, we are victims of the system, so are doctors. And you can see it in how demoralized a lot of healthcare providers are having to do this kind of work. Medicare and Medicaid, which are the models for a publicly funded system, are very well-run systems. They have policy problems, as many programs do, but they are efficient. They've been in the business for 57 years. At this point, they have very low administrative costs. Most doctors take Medicare. A smaller number take Medicaid because the Medicaid reimbursement is pathetically low, often below the cost of delivering care. And currently, this is data from 2021, 2020. This is actually data from 2022 because it comes straight out of the Center for Medicare and Medicaid. There are currently 64.5 million people on Medicare, and that number rises every year as we are an aging population. There are 82 million people on Medicaid. This is the program for impoverished people. Most of them are kids, by the way, which is a really sad thing to think about. And there are some that are dually enrolled, so that doesn't quite add up because there are people on both Medicare and Medicaid. I'm not quite sure that 12.2 number because they haven't updated it in a year, but it's something in there. So right now, someplace around 130, 135 million people in our country are already on these programs. That's about 40% of the population. So making a switch to a program like this is not going to be that as big a switch as you think, because a huge part of our country is already there. Plus there are people in the VA system, plus there are people in the military, and they add up too. So that is pretty much the pitch for why we should have a single payer, publicly funded, privately delivered, comprehensive, universal health insurance program for everyone. I did want to point out that we know that there are different points of view about this, of course. We have grown up in a system that has changed incrementally. We've all gotten used to these changes, but we started in this country with a profit-driven system that has evolved into a corporate profit-driven system, but still has retained that. We have never gone the way of the other industrialized countries of the world to do either a truly governmentally run system or one like the single payer system where one health insurance program for everyone, or what they do in countries like Switzerland and Germany and the Netherlands, which is to have many insurers, private insurers, but not allow them to make profit. So, for example, in Germany, they don't have a single payer system. They have a multi-payer system, many insurance companies. But every person is guaranteed healthy coverage. You cannot be turned down. Health insurance companies are not allowed to make a profit from their health insurance product. They can make a profit from your car insurance and your life insurance and your house insurance. They want you as a client, but they can't make money out of you from healthcare. And they're highly regulated, what they have to cover, how much they have to cover, in a way that has never happened in this country. Even the Affordable Care Act, the changes it made, were a drop in the bucket compared to what other countries do to regulate their health insurance. Myth number one, I'm going to do 4 myths and then I'm going to stop and just do questions. I did put together some like the kind of typical objections to it, but I'm going to let people in the room give the objections to it. So myth number one, Medicare for All will force people with employer-based insurance to lose choice. If I could wave a wand and tomorrow we would have a Medicare for All system and everybody in this country was covered by it. Absolutely true. People with employer-based insurance would lose their insurance, but they would not lose choice, access, or benefits. They would just get it through our improved Medicare for All system, which would give it to everybody. They just wouldn't be reliant on their employer for that. Myth number 2, Medicare for All is not affordable and will cost individuals and our nation more than our current system. I would say that's impossible. We already pay close to twice as much as every other peer country. We already pay more in our public funds, in our Medicare, Medicaid, TRICARE, VA, than most other countries do. We just don't spend it very wisely. If we took all of that money, we already pay in taxes, we already spend, and we actually spent it on healthcare, we should have plenty in the system. Medicare for All, single payer, will turn our healthcare system over to the government, resulting in bureaucracy and rationing. It will definitely turn the insurance company, health insurance, over to the government. That's the idea of it. That's the whole plan. I will tell you, there is so much government bureaucracy right now in healthcare. And as a doctor, you can't see a patient and charge them anything without going through it. You have to provide a code, and that code is one that everybody has to use. And you have to use, it used to be, there was a time when Medicare codes were different than insurance company codes, and no longer. We already have, we're way down the road of government bureaucracy about this. We are also, I love that, but I think if you're gonna have it, you should get some benefit from having it, like get everybody covered with good health care. And make it simpler for everyone. We already ration. We just don't ration. We ration based on, can you afford it? Or do you happen to work for an employer who, for whatever reason, can provide you a good health insurance program? Or do you happen to live in a state that has Medicaid benefits that are compatible with what you need? Or do you happen to have a disease, a specific disease that is covered? Medicare covers chronic renal failure, for example, but it doesn't cover chronic liver failure or heart failure or lung disease. It covers chronic renal failure. Well, that's a fluke of our system. It's great for the people who have chronic renal failure. It's not an intelligent way to run a population-based healthcare system. So I would say we already ration care. Why don't we do it in a intelligent way? And finally, the idea that Medicare for All is just too disruptive. It would be switching to this new system and people will lose jobs and they won't be able to manage. People will lose jobs if we switch, if we could magically switch tomorrow. We won't need 1,600 billing clerks in large hospitals. We wouldn't need every doctor's office to have somebody who does nothing but billing. And we wouldn't need all that time wasted just doing the for-profit stuff. But I would argue that this is okay. And is there a way for me to find a slide that's farther along without having to go through them all? Or do I need to go through them? Oh, yes. So This is my favorite quote, and it's the one I'm going to end with. This is from Elizabeth Rosenthal. She was an emergency room doctor who became a journalist. She's an incredible science journalist and has written a lot of papers and articles and columns for various newspapers, including the New York Times. She wrote a beautiful one called Medicare for All Could Kill 2 Million Jobs, and That's Okay. And it is, because there are jobs in our system that would not need to exist. But as she says, the point of the healthcare system is to treat patients. It's not to buttress a specific part of the economy. And there will be other jobs out there. If you want to read something really intelligent about how our healthcare system works, I don't always agree with her. I think she's still too into the system, but she really knows what she's talking about, and they're widely available. So that is where I'm going to end my presentation, but I really do want to hear questions, discussion, and if not, I have more questions. No, there's one. Oh yeah, actually I said I was going to end, but I do have 2 or 3 other things to say. I'm really sorry. I wanted to do another shout out about the referendum that was passed here in Dunn County. I think it's extraordinary that it passed, even though I do realize it passed by a small margin, but it passed at a time when there wasn't an enormous campaign that went on for a long time about it. And there have been many campaigns about healthcare expansion around the country, and they usually take a year or so, and there's a lot of information out there, and they're difficult campaigns to run. So the fact that in a fairly short period of time, people in your county were able to put that on the ballot and then think about it and vote is really impressive. And then to vote for it tells you something about where people are at. Every time you poll the American people, however you ask the question, the majority of people believe that healthcare should be available to everyone. The majority actually believe healthcare is a human right, if you ask the question that way. If you say, should we have a universal healthcare program? It's way high. It's in the 70s to 80%. If you say, and it should be run by the government, it goes down a little bit. If you say, and your taxes are going to go up, it goes down a bit too. But it never goes down below the majority. It's always at least in the 50s. The same thing for doctors as well. So what you saw here is a reflection of the fact that no matter where you are politically, most people in this country think that healthcare should be an intrinsic right, that we should find a way for people to have it. So kudos to the people who put together that referendum and got it through. The second thing is, the other way that we know that this is, it's not just polling people, not just asking them a question that has no consequences, is when you put it to the test and people vote, they vote for healthcare. So this is a little off topic in that this is about Medicaid, but the Affordable Care Act, Medicaid is a state-federal partnership. It is funded by tax dollars, both at the state and the federal level. So the federal government puts in some money and has a bunch of rules. Every state has to follow the basic rules, but then they're allowed to make a lot of changes within those rules. So it will change from one state to another. But our tax dollars pay for this. And the Affordable Care Act, which actually went into effect in 2014, had as part of its program expanding Medicaid throughout the country. The first Supreme Court case about that basically told states that they did not have to take the Medicaid expansion if they did not want to. So a number of states chose not to expand Medicaid, which would meaning more people on Medicaid and the federal government throwing in more money for those people. The states that are in brown here are the states that have not expanded Medicaid. So Wisconsin is one of them, Wyoming, Kansas, Texas, and most of the South. Okay, all of the South. What has happened since 2014 is bit by bit, a bunch of states that had initially said no to expanding Medicaid have now said yes. And they said yes for a bunch of reasons. Some of them were state legislatures that decided that they couldn't turn down, it was free money. And it costs a lot of money to insure people. And it costs a lot of money to have uninsured people as well. But there are 7 states that have put that question to voters with ballot initiatives. There are referenda or ballot initiatives statewide where people actually got to vote. Did they want to expand Medicaid? And those states, every single time that question was asked, every one of those states voted yes. And those states are Maine, Idaho, Utah, Oklahoma, Missouri, Nebraska, and last week, South Dakota. That's why South Dakota, these 6 of those 7 states are arguably deeply Republican states. In fact, I think the vote in South Dakota and Missouri are probably the 2 most interesting because on the same ballot, one week ago in South Dakota, they reelected their governor by a very wide margin, 20 points or something, who she ran on a platform of not expanding Medicaid. And on the same ballot, the voters in South Dakota elected her and also voted for a constitutional amendment to change their constitution to expand Medicaid. So that happened in Missouri, that happened in South Dakota, that happened in Idaho. This should not be a partisan issue. You know, it is clearly possible for many people in this country to want to vote certain people in for the reasons they have, and still want to make sure everybody gets health care. So that's the reason I put this in. This is not just a poll. I think we know that this is actually how people feel. We don't have that option in Wisconsin because we don't have a statewide binding referendum system. But those states did. And we are now one of 11 states that have not expanded Medicaid. We've left about $3 billion on the table in the last 8 years by not doing that. And what we got for that $3 billion was 80,000 people not insured. That was our benefit for it. So that is yet another just little discipline. Sorry about that. That's a little off on topic, I know. So I'm going to go back to my first slide. We believe healthcare is a human right. If you're going to do it, if you believe that, then you have to find a way to enact it. I think everyone should be in, nobody should be left out. Thanks for listening.
I just wanted to comment on what happened in Dunn County when we did the vote. When the referendum was presented to the county board, many of the people were not supportive, but then they realized they didn't have any impact. It didn't have any impact on the county because it has no financial impact upon the county. They wouldn't have to do anything. They put it on the agenda for the referendum for the election in November. But the thing that really made them decide to do that, to put it on, was because John Calabrese, who's on the county board, got up and told them how much it cost them, that the county was paying for their health care. And so he quoted the amount of money that the county was actually paying out to health care on a regular monthly basis. And as a result, the county board decided, hey, that's a lot of money. We ought to try a different system. And so maybe we ought to support that, getting it on the ballot from the referendum. So I think money speaks to the legislators and the people in power that can help make some decision. And I think, anyway, I just thought that was interesting. That was.
It was $6 million a year.
$6 million a year from Dunn County.
Yep.
It's a lot of money. It's also a lot of money to take care of people who are not insured. Because people who are not insured, they still get sick. They still get into accidents. They still need health care, and they do get it. And we all have to pay for it because they don't have anything to pay for it. It's a huge burden on rural health, not just rural, but city hospitals and hospitals that take uninsured patients. It actually is money out of our own pockets, and not in a very, not in a thoughtful way. And efficient. I do want to point out that there is a handout coming around if you want that has sort of the basics of what single pay is. And I also do have some handouts about our organization. If you know anybody, if you would like to join CNHP, we would love to have you as a member. If you know people who are in healthcare at all, point it out to them. And if you want to be on our mailing list, you can be on our email list without being a member. And I promise you, you won't get spammed because we are all volunteers. Some of us are even still working doctors who, after I finish telling you this, don't have any time to be spamming anybody.
I just have a question, or a comment, when we talk about single payer. A lot of people do think that they're going to be paying more, they're going to be paying more taxes. That's true. But what they're not going to be paying is their monthly premium, nor is their employer. And sometimes I think we need to tell people, that $300 that comes off the top, or that $500 or what, and then, your employer that's paying the other 70% doesn't have to pay it either. Somehow we're not getting that message to people that, yes, you're gonna pay more in taxes, but you're not gonna go bankrupt when you get in the hospital either.
That's right.
Could I just add to that, what Jane said? There was a community conversation maybe a month ago, and that same thing came up. And the net is the person, the individual, that will actually have less money going out of their pockets. Yes, they're gonna pay more, but they're gonna save with all these administrative costs that you showed. That's where the big savings is going to be. And people that don't really pay attention to the details of this, they don't quite grasp what Jane just said. And so what you're doing today, this education, is good. And so I applaud what you're doing, and doing more of this, and even, I hope this is shared with Representative Moses, who wasn't here tonight, because this is good stuff.
Yeah, I'm really sorry he wasn't here, with other people who are invited, because we really should be having a conversation about it. Because it's absolutely true. I'm not an economist, and I'm not a tax policy person, but I can't see any way that you get to that system without having our taxes go up in some manner, whether it's individually, or employer, or whatever. But if you remember that you're not going to be paying premiums, deductibles, copay, coinsurance, that's a huge amount of money out of our pockets that you won't have to pay. We are also the only country, the only industrialized country where people go bankrupt because of healthcare costs. In fact, the #1 cause of bankruptcy in this country is medical care. And most of the people who go bankrupt for medical care had insurance when they first got sick, because of all those other things. In other countries, you're just not gonna go bankrupt. Other bad things might happen to you, but that won't.
Well, there are fallouts and consequences beyond your hospitals and your doctors and so forth. My husband and I ran a pharmacy. Okay, so we had to employ people to do the billing too after a while. We opened in '83, which was when these things were starting to get out of hand. We didn't know that. But having to have people employed simply to do your billing adds to the costs of running the pharmacy, adds to the cost of your toothpaste as well as your drugs, It all plays out. And the doctors used to have one person to do their billing, and then had to band together in groups with a couple of people to do their billing, and then pretty soon, how many? It's crazy.
No, that's right. The pharmacy thing is really interesting, because it used to be, if I wasn't quite sure, like someone was gonna pay out of pocket, or they could only, afford something, I could call the pharmacist, and we could like figure out, is there something that will work for them that they can afford? They can't anymore. They have to do it through billing, because it's so complicated, because everyone's got a different system, every insurance company is different, they keep changing their formula. All you can do is submit the bill and see what happens, whether it gets paid or not.
And if the patient is allergic to an ingredient, a component of that medication, but there's another medication, another company that makes it with a different component that's not covered by the insurance, they can't get the one that won't make them sick.
That's right. Yep.
There's been a trend recently of private equity firms buying practices and for the purpose of making a profit. If there's public funding of privately delivered healthcare, what would be the check in the costs? I mean, could that not create a spiraling of costs if there's still a profit motive at the delivery level?
That is a really good question. If you Google private equity and healthcare, there have been a bunch of articles recently that have been in the national press. Some of them, so the New York Times have done 2 really interesting, detailed articles about private equity takeover of hospitals in this country, and I think of long-term care was the second one, because actually most of hospice now in this country is owned by private equity firms or for-profit firms. That was not the case 20 years ago, when they were mostly nonprofit and community-based. They have already taken over big parts of dental practices and of vet practices. And the trajectory is terrible, because they are truly, private equity is like, companies that are looking for investment opportunities. And so they're really in it for the money, which is fine. We're a capitalist country. You're in it for the money, you're looking for a good opportunity. We would need to make sure through legislation that could not happen. One of the ways that would probably not happen is that part of the detailed economics of the proposal is to do what's called global budgeting. Global budgeting means that it's moving away from a system in which you say, well, we did an appendectomy and it cost this much, or we gave out a and it cost this much, or we did this procedure. Instead, the hospitals would get a budget for the year, and within that budget, they allocate how they're spending their money. So you could not just have a system. I don't see how you could have a system in which there's just unlimited funding for whatever. We don't have unlimited funds. We're talking about using the funds that we already have and just doing it in a more thoughtful way that's based on what we know works. So I'm not qualified to answer that question, but I do know that is a question that people have asked. One of the really sad things that has happened with the private equity takeover that's actually been going on for quite a long time, and there's a sordid history about it. Most of the medical practices that get taken over that way end up failing because private equity firms are really only interested in them for a few years, and once they've gotten the profit out of the system, they move on. And meanwhile, this is your practice, your career is now gone. The most famous cases recently was in Philadelphia, where the largest public hospital in the city of Philadelphia, which had been a public hospital for 250 years, was purchased by a private equity firm for the real estate, because it sits in central Philadelphia. And they basically used it as leverage. They took debt out against it for their other ventures, and within 2 years, they had closed the hospital and sold the land. And they made a lot of money, and Philadelphia's public hospital is no more. So right now, our system allows it. We would have to make sure that we don't going forward.
I think somebody back there had their hand up.
Somebody did. And I don't know any of your names, so I'm just gonna point at you, like that's a polite thing to do.
As I understand it, Social Security and Medicare are funded by regressive taxation, payroll taxes, and unlike similar systems in other countries, would the funding of Medicare for all be based on a progressive tax?
Hopefully. Medicare, actually, those of us who are old enough remember we used to have something on our paycheck that said FICA, and we never knew what that meant. Sometime 20 years ago, they actually changed that and they now call it Medicare. You can see it on your paycheck. It is payroll tax. That is how Medicare is funded. So it is quite regressive because you could make money in lots of other ways and not pay into the Medicare system, but still be eligible for Medicare. Social Security is an easier fix because although that's not just payroll taxes, that's all your income. Like self-employed people pay Social Security, but it is capped. If you make more than a certain amount of money, the amount you pay into Social Security every year stays the same. If we release the cap on Social Security, we probably have plenty to see us through the next 100 years. Medicare is much harder because we don't have that. We only have payroll taxes. So yeah, the tax code would need to change. But the tax code will need to change because otherwise you can't fund it you still have to have enough income coming in to fund all the people. If 40% of the country is on it now, that means 60% are not. So to switch them over from private for-profit insurance to the publicly funded government insurance requires more money into the system. Some of it is still talking about taxing employers. A lot of countries tax employers as well as employees. So there are various ways of doing it.
Yeah, I wanted to clarify that if you take all the government-funded programs, Medicare, Medicaid, the VA, the military system, and the Indian healthcare system, the total is how much percent is already?
About 40,
About
a little bit more than 40. Because there's some overlap. There are people who are in the VA and also in Medicare, you know, and so those numbers, they're not just simply adding every one of them up. So it's at this point around 40%. And the biggest increases are because we're an aging population. So to get onto Medicare, you have to be 65 years old and have worked for 10 years in your life so that you're eligible, like you would be eligible for Social Security. That's almost everyone who's 65 years old, right? So every day, many, many more people become 65 years old. And that's the baby boom, we have another 15 years, I think, before we start seeing the downside of that. The other sad thing is that the rise in poverty in our country means that the Medicaid population has really increased. Even a few years ago, it was a few years ago it was in the 62 million people. We're now at 82 million people, mostly kids. You had it, only because you talked once, so everyone gets a chance.
So with the current, I know you said that, and I think we could all agree that this should not be a partisan issue. And probably all politicians, or many, on both sides, get a significant contribution to their campaigns from the insurance companies. How can we ever get there?
One of the reasons I do believe it is not a partisan issue, even though it seems like it is because you're totally right. Lobbying from not just the insurance companies, but pharmaceutical companies, the medical device companies, hospitals, which even the nonprofit hospitals operate as if they are for-profit hospitals in the way that they game the system. And to my sadness, met some medical organizations as well. The AMA, the American Medical Association, owns the codes, basically. They created it and they have ownership of it. And they actually make money out of some of that too. So it is a complicated, very, very complicated system. And I think the estimate is that there are 3 lobbyists per congressional rep that work full-time every day lobbying for their industries. It is a huge amount of money and it's very hard. But beyond that, I think there's a deeper problem beyond that. I think there is a way to get beyond money. But the deeper problem is that we have grown up in a system where we think that this is how it should work. The kind of pushback that I hear from people people who are on the left who are more for Medicaid expansion and more healthcare is that they don't want to take the profit out of the system because it drives innovation. Because how are we going to have great new treatments and drugs if we don't let pharmaceutical companies take the profit that they need out of it? And they really truly believe it. And they also do believe that that motivator is really there. There is a ton of evidence that most of the new drugs that come out are either copycats of ones we already have, either not necessary or not big improvements, that the special status that they have where they can hold a patent for 3 times longer than any other product and then tweak it a little and hold it for another 3 times longer, that they can charge us so much more money for the exact same drug that they will sell to another country for 1/3 the price, for example. You know, you can go to Canada or the Netherlands and buy the exact same drug that came out of a factory here for about 1/3 the price. So obviously they're still making money when they're selling it for 1/3 the price. There's just a belief that that profit is necessary for innovation. I don't think it's true. And we also, most of the drugs that are really valuable the basic research has been done through publicly funded programs, through our tax dollars, through research done through the NIH or universities, and then it's the drug companies who then market it and create it and make the money on it. So there are lots of ways of dealing with it, but I think deep down we have to analyze that notion that profit is the only motivator for progress. And if you grow up in a system like this, it's really hard to analyze it because it seems so normative. If you grow up in a system where profit is not part of it, you can see it a little more clearly. So I think it is true on both sides. They both need it and see it. On the other side, I have also heard some pretty terrible feedback about how people don't deserve healthcare. There's also the point of view, not everybody believes that healthcare is a human right. I've personally done a lot of lobbying with our own legislature over the years about the Medicaid expansion particularly, because this is children and sick old people, you know, who need long-term care, who need vaccines. This is the idea that you are not gonna take free money so that they can have that care. It's crazy. But I was told by somebody in the legislature that I think his response to it was, what can we do if people choose to be poor? That was his response. You know, so I don't think 5-year-olds choose to be poor. I don't think anybody chooses to be poor, honestly, or hardly anybody. But that attitude, that idea that your healthcare is just yours, has nothing to do with me, that I think we might get through to some people with education. And as it turns out, even most people who don't really want a lot of government in their lives can see that we're all connected. Somebody in your community, I mean, if nothing else, you would think COVID would have taught us that if nothing else, that we are all connected, that our health affects other people, that other people having COVID and coming in and giving it to you affects your life. And that, so it is true for this. People who overrun the hospitals who cannot pay for their care because they can't get insurance, means that you also don't get the advantage of that hospital. Rural hospitals have closed at an alarming clip around the country. And that means that whole communities don't have hospitals anymore. So we could see ourselves as a community together. We could make progress.
I think it's getting late.
Last one.
I was wondering if you would discuss the difference between Medicare and so-called Medicare Advantage. Because I don't really think of Medicare Advantage as being Medicare anymore.
You guys have a business meeting. Medicare, very shorthand is Medicare Advantage is a program started almost 20 years ago that is the beginning of privatizing Medicare. And what it did was allow Medicare recipients to choose to buy private health insurance, which is called Medicare Advantage, which some of us think should be called Medicare Disadvantage. And that would take the place of your traditional Medicare. And the biggest difference is that you are now dealing with a private for-profit insurance company under their rules. And you will get the benefits that they say you're going to get, but they can change them, they can charge you money, they can drop you, they cannot accept you. With Medicare, you are automatically accepted in the first 6 months after you're eligible. After that, you're subject to underwriting. Unfortunately, that's still the case. So Medicare Advantage
If you
is,
go off Medicare to take a Medicare Advantage plan, it's almost impossible to get back on.
you can go back to traditional Medicare, but what you may not be able to do is get a supplemental plan. Traditional Medicare has gaps, has things you need. So
So if anybody wants to have other questions that you might want to talk to her about, you could go out in the hallway if you have other questions, and because we're going to have a business meeting. And it sounds like the profit motive is the issue that is the it sounds like that's not the main issue.
It's all about the money.
Thank you very much.
Right.